sometime in the past, they saw that people had a lesion which was characterized by thickening of glomerular basement membrane. So that is why it is called membranous nephropathy. And similarly, minimal change disease, because they looked at the glomeruli under the microscope, and under light microscope they could not find any abnormality. So minimal change. Obviously, something is going on. That is why the patient or the child is leaking protein in the urine, but the change is not visible on light microscopy, and so on and so forth. FSGS, because the morphological lesion was slender. But that doesn't mean that the the exact disease could be just tagged with the morphological lesion. FSGS now we know can be because of a number of reasons, and we can talk about it. And similarly, membranous. So that's one point. So that's one point I'd like to make, so that you have that clear. And why it is important to know that is that you should expect changes in the way we classify these diseases as our understanding of pathogenesis improves with the use of modern technology. So that is expected, and if the classification doesn't change, that means we are not making sufficient progress. That's number one. And the second point, which is a question to you, and the question is not necessarily to trouble you, but to just stimulate your thinking. Dr. Kher also said that even before we knew that there was an antigen and against which the antibody, like anti-phospholipase A2 receptor antibody, was responsible for development of membranous nephropathy, we had started using rituximab. So why did the people who initially start using it thought that it was a good idea to use rituximab in patients with membranous nephropathy? Why do you think? Anyone can make a guess? Yes. So why do we want to use anti-B cell therapies?
Antigen mediated disease. That's why we want to suppress antibody production.
Why do we want to suppress antibody production?
Yeah, but we didn't know at that point of time that this is you are into nephrology when PLA2 is already existing.
Yeah.
You can look at like people like me when PLA2 didn't exist. 2009 was the first time it was described by any name? But Dr.
Larry Beck and David Salam's lab in Boston.
Yes, in Boston.
But again, coming back to you are right that antibody suppression. Why did we think that suppressing antibody is a good idea in patients with membranous nephropathy?
So it could be due to in IF there are deposits. IgG deposit.
Right. So we already knew, because the only abnormality that you see on immunofluorescence is a rich deposition of immunoglobulin molecules on the glomerular basement membrane. So immunoglobulin molecules are antibodies. Antibodies are produced by B cells. So suppressing B cells makes sense. So even though you are not exactly sure of the nature of the antibodies, you know that antibodies have to come only from B cells. So you want to suppress B cells, right? So that is why that was a sensible idea even before we knew what was going on in these patients. So that's an important one. And the second one is that before that, the treatment that we used, and we continue to use it even today, was a cyclophosphamide steroid-based regime. And that is a very non-specific way of suppressing the immune system, right? So it is like the difference between using targeted therapies, and rituximab is also not fully targeted therapy, and a therapy like steroid cyclophosphamide is that when you attack enemy territory, you use either you can use a carpet bombing approach, that you flatten everything, or you can use perhaps a targeted bombing approach, laser guided bombs and so on. You might have heard about. I think that's a bit of a analogy. It's a terrible analogy. We don't like to use war analogies, but you know it makes the point. So that's an important one. And second is again coming back to the issue of how do we classify membranous nephropathy so far. So far we have classified membranous nephropathy into primary and secondary, right? And primary where we could not find any cause, and secondary where we thought that membranous nephropathy developed in the context of something else, such as malignancy, some chronic infection like hepatitis B or C or something like that. But now that paradigm has changed. Now we know that even people develop membranous nephropathy in the context of one of those other conditions can have abnormalities or antibodies directed against one of these antigens that have now been found. So we have published papers, and many others have published papers, that individuals who have membranous nephropathy in the context of hepatitis C infection, even if you cure their hepatitis C infection, they might continue to have nephrotic syndrome, and they have antiphospholipase A2 receptor antibodies also elevated in their circulation, and there are deposition of antibodies in the kidney biopsy. So in that case, you have to go ahead and treat the membranous nephropathy just like you would treat quote unquote primary or idiopathic membranous nephropathy. And the same thing is true about the other new antigens also that have come. I think you should remember a few names. Already Dr. Larry Beck and David Salan's name was mentioned. But the person who is making really the most contribution to identification of these new antigens is Dr. Sanjeev Sethi. Dr. Sanjeev Sethi is at Mayo Clinic, and
You must have heard him also. He's been coming very frequently.
He's been coming.
Very frequently.
He has family in Delhi, and so he comes to Delhi quite frequently. And the approach he has taken is quite unique, and you should know about that also, because someone can ask you. So what he does and his team does is that they take these kidney biopsies of patients with membranous nephropathy. They first try to ascertain that the biopsy that they have is of individuals with membranous nephropathy not due to one of the known antibodies, right? So because they are looking to identify new antigens, and they use a technique called laser capture microdissection. And laser capture microdissection allows them to pluck out the glomeruli from the kidney biopsy. It is like playing a video game. For those who want to know, I have done laser capture microdissection myself, so I know, you just target the laser around the glomerulus, and it gets cut out, and it gets dropped into a tube. And then so now they have the glomerulus, and so the glomerulus will contain this unknown antigen and antibody against that unknown antigen. So then they digest that glomerulus using various proteolytic enzymes. So what that does is that it cleaves whatever protein is present in the glomerulus into small peptide fragments. And then those peptide fragments are run on a technique called mass spectrometry, mass spec, right? And again, cutting a long story short, I don't want you to learn everything about mass spec because that's not helpful. Mass spec allows using bioinformatic techniques. It allows reconstruction of the small peptide fragments into larger protein molecules. And in those larger protein molecules, then they try to see, are there any protein molecules that are normally present in the glomeruli, because the antibody should be against one of the components of the glomerular basement membrane, right? For it to be pathogenic, it's very important. So if they find it, then they do other things. For example, they will generate a recombinant molecule of that, and then raise antibody against it, and then use that antibody to stain the glomeruli. And if they can confirm that there is staining, then they have identified the new antigen. So that's the technique that Dr. Sanjeev Sethi and he publishes every few months a paper describing a new antigen in membranous nephropathy. And they already, I think, at least 10 antigens have been identified. But the most frequent by far, 60 to 70%, in some series even 80%, is antiphospholipase A2 as the culprit antigen. And the second most frequent is?
Around 10 to 15.
L1 and then THSD7A, right? So these are the more frequently seen antigens. But then the rest are present in very small numbers. But let me again ask you a question. If you have a patient with suspected membranous nephropathy, or somehow you have confirmed the diagnosis of membranous nephropathy on light microscopy, and you want to now order immunostaining on that light microscopy slide, what will you order? What will you ask your pathologist to do? Because they have now access to staining for so many antigens. as a practicing nephrologist who has to manage a patient, what will you ask them to do? Let's put the fact of that we can measure antibodies in the serum to one side for a moment. Okay, that's we are not considering that. We are simply looking at
You biopsied a patient, and it turns out you had a nephrotic syndrome patient, and you biopsied a patient. Your clinical suspicion was membranous nephropathy, and it turns out to be membranous nephropathy.
Yeah.
So now you want. Well, the question is, what kind of antigens, immunostaining would you want your pathologist to do?
why.
Because that is the most common. If that comes negative, then we can do it.
And so what if it comes positive? Please sit down, keep sitting.
So if it comes positive, what does it tell you?
Primary.
So it tells you that it's a PLA2 positive membranous nephropathy. But would you ask for others, or
And we'll first try to, on the history, we will first try to see whether it could be a primary or a secondary, and we will order the staining according to the diagnosis. For example, agglutinin is associated with malignancy. So if I am suspecting a malignancy related membranous nephropathy secondary, then I would include agglutinin as one of my markers to study in the vaccine.
How does it help you in managing the patient better?
Sir, for example, if it comes out to be a PLA2 positive,
All right, let me ask the question somewhat differently. What is the principle behind ordering any test?
whether to change
Two or three reasons, right? Or 3 or 4 reasons. One is that you want to make an accurate diagnosis. Right?
I think first would be an accurate diagnosis.
Accurate
You
diagnosis.
must be
Second
sure
is-
as to what it is.
Second is, what is the purpose of making an accurate diagnosis? Because you want to manage the patient properly. If you have an accurate diagnosis, you will manage the patient appropriately. And the third is that you want to perhaps estimate the prognosis of this individual. So, does identification of the antigen help you in managing the patient better? Identification of the antigen on kidney biopsy.
So
If
what
you-
does it tells you that the diagnosis is. So if you find PLA2 on immunofluorescence in that biopsy, then it tells you that it's positive. So what will you do next? Will that be enough for you to manage this patient, or you think that now you know that this is primary membranous nephropathy, but how does this help you in management, which is the second thing that you would want?
We can prognosticate the
From the histopathology.
from the serum level of,
So you will need,
order.
that's what,
So we put the serum. I
I
asked you to
needed
put that,
that
to one side.
one
We
side.
we will come back to it. I'm specifically asking you
Okay.
to think about how will you order immunofluorescence investigations.
see, immunofluorescence, when you send a biopsy, you send for regular immunofluorescence, which is to look for immunoglobulins complement. And then most people also look at biopsies of alpha and kappa lambda tails. So they also
That's a
look at
standard
those
parameter
as the standard.
that
In
you have
addition,
done. You have identified membranous nephropathy. Now you are curious and you want to go in and make further tests to identify.
So you want
the
to find
exact-
out, is it PLA2 positive, is it PLA2 negative? So you will ask for a PLA2.
So
Staining is
the bottom line is that identification of the antigen on kidney biopsy doesn't help in patient management at all. Right? It doesn't help. So you should keep that in mind, right, when you are ordering a number of tests, because each test costs the patient money. Each additional immunostain will cost the patient extra.
Okay, these days now on a biopsy, you have all the antigens now available. Now Lal offers
Yeah.
all the 6-7 antigens currently. semaphorenes and NEL and
It all comes at a cost. Right?
yeah, it comes
Comes
at
at an
6,000
extra
rupees,
cost.
6,000 rupees extra
Extra cost.
if you
So,
want to look at this from that. But yes, I would agree that it doesn't
help you.
it helps you to make a correct diagnosis, and it tells you that there is the only problem is that in serum I have a question on that which will come back to it.
And to
But
your point, if you want to identify malignancy associated GM, you look for malignancy. You don't go to the antigen, right, to make a diagnosis of malignancy, right? So we should look for malignancy in all patients with membranous nephropathy, but that also should be done in appropriate age, appropriate screening for malignancy, right? It's not like just because someone has membranous nephropathy, now you start ordering PET test in everyone. Right? That will be an overkill. So if you want to make a diagnosis of malignancy, look for malignancy in the way one should look for malignancy. Right? But again, back to you.
Yeah. No, I thought that the question is that the point is that basically it is the availability of the serological test which has changed the way we start looking at these patients. The staining may be present and that might give you a link, but whenever you suspect membranous nephropathy and turns out that in many patients the biopsy is not done, you have an adult patient, a differential diagnosis on top is membranous nephropathy. Many patients don't agree to do a biopsy and therefore you might do a blood test now which is available serologically. The first question, what are the two tests which are available? How is serum test done? So what are the two methods by which we measure blood? So what's the difference between immunofluorescence and the ELISA?
Immunofluorescence is quantitative.
Immunofluorescence is quantitative or ELISA is quantitative and immunofluorescence is usually a semi-quantitative or a dilutional method by which you can go till the end of the dilution till you see positivity of the test. The dilution you'll use as a qualitative test of positive or negative. But then you can do some titers, which is more sensitive. Immunofluorescence is more sensitive test. So the question which I have for Vivek was that since these two methods are available now, so which method you think should be used by a physician in their first evaluation that okay, this is positive, and does the second question, which is a continuation of the same one, that if we find different titers, do they mean different things for management purposes? In the sense that as I have grown that if there is low risk patient who doesn't have that much of progression, I should not jump onto immunosuppressive therapy and we should continue to see because 30% of patients may go into spontaneous remission. Now, does PLA2 also help in identifying people who may be at higher proportion of going into spontaneous remission on its own? So, which test to use? Is there important? Should we use both of them or one of them? And then, does it help us to identify people where we should not give aggressive immunosuppression on front, and which patients we should use?
So very good question. I think this
which
is one of the most
from
practical questions that you will have to ask yourself when you see a patient with suspected membranous nephropathy. So before actually talking about the choice of tests, there is another question. Do we need to do? All right, let's just answer that question and then we'll come to the other one. That if in answer to your question, the question that I would first again, and here we keep into mind what is the benefit you will have from a test versus the cost or the cost of the test. One, cost doesn't mean only financial cost, but in terms of the waste of time and so on and so forth. So the maximum advantage you get from a test is the test by which you get the maximum advantage in terms of knowledge is the ELISA. Right? Why? Because if ELISA is positive, you know that there is antibody against phospholipase A2 receptor antibody, one, and second, you get a titer, and the titer is important, which brings me to the second question of Dr. K. The titer allows you to risk stratify the patient in combination with other factors, of course. Titer is not the only determinant of risk stratification, but titer is an important component now. The higher the titer, the more likely that a patient will not undergo spontaneous remission. Right? And there have been attempts to try and find a threshold that will be able to identify patients who will not undergo spontaneous remission and therefore should be treated using immunosuppressive therapy. So here I'm taking care to qualify that treatment doesn't always mean use of immunosuppressive therapy, but those subjects who do not undergo spontaneous remission or remission with just non-immunosuppressive, non-specific therapy will need to be identified. That is one of our goals, right? One of our goals is to quickly identify individuals for whom we will require a different approach to treatment. So work is still ongoing, but the KDIGO has proposed a threshold of 150 RUs or relative units to identify individuals who are at the very highest risk of progressive worsening of kidney function if they have membranous nephropathy. And between 50 and 150 is intermediate risk, and less than 50 is relatively low risk, right? So that's an important one. So if you have to order one test, order ELISA. Now a follow-up question would be, what if ELISA gives? So ELISA, there is the commercially available ELISA is made by a company called Euromune, and the Euromune ELISA has a positive threshold of more than 13, right? 13 or 13, 14, some such number, right? But there is still some uncertainty or some controversy whether values between 2 and 13 do they indicate positivity, because a lot of variation is seen in that range. So you are left with uncertainty. Therefore, if you have ordered an ELISA and the ELISA comes back negative, right, which means less than 14, then that is the time you would actually go ahead and order a immunofluorescence test, because it is more sensitive, as we just discussed a moment ago, right? So the small number of people who may have the antibody, but the antibody is not getting detected by ELISA, will be picked up by indirect immunofluorescence test. Obviously, indirect immunofluorescence doesn't allow you to monitor the titers or allow you to risk stratify these individuals, but it is safe to assume that they will be low risk because their ELISA was not positive and therefore they are not high titer. It will be safe to assume that if they are only positive by indirect immunofluorescence and not positive by ELISA. Okay? So that's an important one. But now this takes me back to one question as to how do we most optimally make use of this now very, very useful investigation that has become available to us. So if an adult patient with nephrotic syndrome who doesn't have microscopic hematuria, who doesn't have any hypertension, and who doesn't have any renal insufficiency comes to me, in the past when Dr. Kher and I were training, we would have gone ahead and done a kidney biopsy. But now I would not do a kidney biopsy, but rather order an anti-PLA2R test in such an individual. If an anti-PLA2R test either by ELISA or by indirect immunofluorescence comes positive, you can be absolutely certain that the diagnosis is membranous nephropathy, PLAR2 related membranous nephropathy, right? It picks up only PLAR2 related disease. And now KDIGO says that you don't have to do a kidney biopsy in such individuals. So please remember, what is the kind of patient we are talking about? These are adults. These are adults with nephrotic syndrome who have no other atypical features and EGFR of more than 60 mg/min, right? There are a number of studies which have come. Firstly, one study came from Mayo Clinic, led by Dr. Fernando Fidenza, and then there was another study which was a multi-country study, which looked at the question: did the addition of a kidney biopsy to those individuals who had positive anti-PLA2 or antibody in the circulation, did it add anything to therapeutic decision making? Because as I said right in the beginning, that the point of ordering any test is if it influences your decision to treat the patient in one way or another way, right? And what they found is that if the GFR was more than 60, then biopsy findings did not make any difference to treatment. But if the in those subjects who had eGFR of less than 60, they found one patient who had some interstitial infiltrate. In a majority of even those subjects, the biopsy did not give them any new information, except in one subject. So the KDIGO recommendation is that if the eGFR is more than 60, then you don't have to do a biopsy if the anti-PLA2R has come positive in circulation. So this is a very important piece of information and practice point, because you save the patient from undergoing a potentially invasive risky procedure, right? So this is one major change which has come in the current KDIGO guideline.
Yeah, so this was also the question already which you covered, which is good, is that you do not necessarily require, which is a huge paradigm change. Previously, at least in my training era, it wasn't that if there wasn't, and we would push people to get biopsies done. Now if there is a patient who doesn't want to get a biopsy done and you have a plaque positivity, there is no reason to do the biopsy unless there are specific reasons like renal failure. Because of renal failure, you don't know what is the cause of renal failure. You don't think it is related to membranous nephropathy. The onset of the membranous nephropathy doesn't produce renal dysfunction in months or maybe in some years as well. It takes a long time for membranous nephropathy. So if you have somebody presenting, then obviously you will need to do a biopsy in such a patient. So this is important that you might, and this will be while you are at this two tests being done. And why I feel it may be important to know about the both tests is that while treating, we'll come to that question, the antibodies come down with treatment, whatever treatment you might. The antibodies come down. And antibodies coming down is a good sign. It's an immunological kind of a cure in this kind of a patient. Now, the question is that sometimes what you do is you find that the antibody by the ELISA is come down less than 40, but patient's proteinuria continues and there is still continuing hypoalbuminemia and all that. So, would you think that ELISA at that point of time might, and in fact, in one of the case scenarios, Perironco had also mentioned that probably what they found was that when they combined the two tests, they found that the ELISA was positive here. The ELISA was negative and the immunofluorescence was positive. And initially they thought that since the ELISA is down, they didn't treat him with further immunosuppressive drugs. But he continued to be progressing in as far as proteinuria was concerned, and then became hypoalbuminemic as well. So then they realized, did the test again, and they found that the ELISA was still positive. So they went ahead and gave immunosuppression to that patient. So would you think that that would be of a practical importance in the management as well? We're talking predominantly of management, so do you think that that combination might help in that situation? I thought I'd sort it out.
Absolutely. I think you raised 2 or 3 points here. Is that now that we have done the ELISA and found that the antibody level is elevated and we have a titer, how do we use this titer? One is that we use this to make a diagnosis. Second is we use it to risk stratify individuals. And the third is that we use the titer to monitor the progression of the disease. How is the disease progressing? It is an immunologically mediated disease, as we all understand, because as you all correctly said, that it is B cell dysfunction which leads to development of antibodies. Now, what causes that B cell dysfunction leading to development of antibodies? That's another question which we will not discuss today. right? So if the antibody level is, I think the way it happens is now the thinking is that the body or the immune system at some time, because of whatever has happened, starts producing antibodies against antiphospholipase A2 receptor antibody, and individuals continue to have accumulation of these antibodies in their circulation. Once the level of antibody in the circulation crosses a certain threshold, it goes and gets deposited into the glomeruli. Right? Once it gets deposited into the glomeruli, so there is an interesting phenomenon at that time that might happen. It is possible that the antibody that the body is producing, all the antibody that is being produced might get deposited in the kidney, right? Because there are unsaturated antigen binding sites present in the kidney. So at that time, if you pick up a patient right at that time for some reason, if you do a antibody measurement in the serum, you will find that there is no antibody. All right. But if you do a kidney biopsy at that time, you will find that yes, the staining for PLA2R is positive. And what is this phenomenon called? It's the sink effect. It's like, kidney is acting as the sink and or a sponge. It is absorbing everything. All right. So that's number one. But if you allow sufficient time to pass, then the antigen binding sites or antibody binding sites in the kidney will get saturated, and then the antibody will start going up in the circulation. All right. So so this is now you are able to pick up the immunological activity by measuring this antibody in circulation. And similarly, what happens is that whatever, either spontaneously or in response to treatment, if the immune system is shut off and if it stops producing antibody, the first thing that will happen is that the antibody in the circulation will start going down and it will eventually disappear. Let's assume for a moment that it truly disappears completely, all right? But the kidney will still have antibodies stuck to the antigen, all right? So the membranous nephropathy lesion will still remain clinically active, and it takes some more time for those antibodies to be slowly disposed of. Therefore, the clinical activity will continue for some more time. So there are now, in the past we used the only concept of remission in nephrotic syndrome, which is true for other conditions, was that you follow the proteinuria. If the proteinuria goes away, then the patient has entered remission, which is still the case, but now we use two different terms. One is a clinical remission, so this is clinical remission, and second is an immunological remission. So immunological remission you document, and that brings me to the specific question that Professor K asked. When you document that the immunological abnormality, which is the presence of the antibody, has now gone away. Right? So again, coming back to the original point that immunofluorescence is more sensitive than ELISA, if you want to be absolutely convinced and you want to document true immunological remission, then you should do immunofluorescence. Not that it is required in practical terms, but because in practical terms you are looking for an initially elevated antibody level to have come down significantly, which ELISA allows you to do. But if you are still, if a patient wants to know because of whatever, because they are very, very anxious, or they want to truly know that whether I have undergone remission or not, then you would want to go ahead and do an indirect immunofluorescence. So that is the answer to the specific question that you asked. But in most clinical situations, it is not required.
Yeah, it would not be required. It would be a rare requirement that you would usually be able to identify most patients with an ELISA, and that should be possible. Other question?
Sorry, you had also asked a question. So, if a patient has exhibited decline in antibody levels and the antibody has become negative, even if a patient continues to be proteinuric at that time, I would hold my hand because clinical remission usually is preceded by 2 to 3 months by immunological remission. So you would expect at this time, if a patient comes and says, मेरे तो पैर अभी भी सूजे हुए हैं, मेरे urine में अभी भी protein निकल रहा है, you will have to counsel the patient and reassure them that most likely you will enter into clinical remission, and I expect there to be a gap of between 8 to 12 weeks for that to happen.
Yeah, actually, don't get disappointed. If you see that there has been a significant reduction at 3 months, in a PLA2 antibody, then you reasonably assure that this is a patient who's likely to get a clinical remission also. The clinical remission might take 3 months, but sometimes slightly more also. So don't get disappointed. So it's good to monitor. You would recommend maybe what if you have done at the time of diagnosis. Now you decided to treat this patient. You treat this patient with whatever immunosuppression you wanted to know. We'll come to that. Does PLA to help us to identify which patient should be treated with which kind of? Because that's another important question. What kind of immunosuppressive drug should you use in these patients, and do different titers entitle a patient to a different kind of? Is there some evidence for that? That's another question we'll ask doctor. Yeah, but it's important to keep in mind that the patients who achieve an immunological sort of a remission, they are the ones who are likely to get into a clinical remission as well. So it might take some time for that remission to come forth. The question I have is that would titers allow us also to choose a particular kind of? You see, these days, now the therapies which are standard therapies for cyclophosphamide, steroids in different combinations of Ponticelli regime, the multiple variations of Ponticelli regime which are being used across the world. The second therapies which came up was the rituximab, and the third is either CNI along with some steroids. These are three general alternatives. And do you think that different kind of titers will, you think that that might be, you might choose a particular agent if the titer is too high, and if the titer is low, then maybe you choose another therapy.
Right. So, titer in isolation by themselves usually don't help in choice of therapy. Both choice of therapy and whether or not to treat a patient. You have to use the titer in combination with a number of other features. The amount of proteinuria, is the patient severely symptomatic, is the patient developing complications of nephrotic syndrome, etc. So all of those factors taken together should help you in arriving at a decision whether or not to treat an individual. Similarly, which regime to use will be dictated by two or three things. One is, of course, the locally available resources. The patient may not be able to afford a treatment which is more expensive. But also, if a patient falls in the so-called very high risk group, right, and presents with development of complications, then at that time, the recommendation is to go ahead and use the regime which has been shown to be most effective in inducing a remission and preventing the development of kidney failure in the long term. And what is that regime which has been shown to be effective in doing that? Yeah, so this is the only one, the only regime which has been studied for a long enough period of time and been repeatedly in multiple trials proven to prevent the development of kidney failure and reduce the rate of complications is this alkylating agent based regime, most frequently cyclophosphamide and prednisolone, and in the original trial Dr. Ponticelli had used chlorotoluene, right? And again, to risk stratify, we do use antibody titers. The highest antibody titers will put the patient into higher risk category always.
Yeah, so it's important, I think, many times people sort of tend to look at these antibodies and then don't look at any other factors, and then start thinking that rituximab is the only therapy that needs to be given to this patient because it's an antibody suppressing therapy, and therefore these are the ones which are useful and the most effective, and the one which has been best studied so far, the standard of care till recently has been the alkylating based therapies. And so don't necessarily only use PLA2 antibody. You will have to use all the clinical features, the age and all other factors which are extremely important in determining. Use PLA2 also. Now that that's available, so put it into the algorithm. And I think this is what I think he was monitor. There is an algorithm for risk stratification in these KDIGO guidelines.
Yeah, so this figure I have drawn using the approach suggested in the KDIGO guidelines is that you do a risk evaluation. You do a risk evaluation at baseline, but you repeat the risk evaluation periodically also. And the suggested time periods in the guideline is at 1 month and 3 months, right? And the various factors that you take into account to risk stratify is, does the patient have any thromboembolic complication? What is the duration of proteinuria? How much is the proteinuria? Right? What is the EGFR at that time? And in Dr. Jack Wetzel's lab in the Netherlands, they have shown that presence of elevated low molecular weight proteins in the urine is an indication that chronic tubular interstitial damage has started, and therefore they use that also to risk stratify. And of course, lastly, which is the most recent discovery, the level of the antiphospholipase receptor antibody. And you can classify using these, and there is an algorithm, there is a table given in the KDIGO guideline, you can refer to that, of what constitutes low risk, what constitutes moderate risk, what constitutes high risk, and what constitutes very high risk. So if the patient falls in low risk category, then we just observe the patient at that time. We don't do anything. We of course give them symptomatic treatment and give them ACE inhibitors, angiotensin blockers, etc. Moderate risk group, you can then you have a few options. You can still adopt a wait and see approach, or at that time you might want to use the rituximab based therapy because that is thought to be less toxic compared to alkylating agent based therapies. And some people, especially in North America, would use CNI. My personal recommendation is to never use CNI in a patient with glomerular nephropathy.
That should be the last choice, in my opinion.
Yeah, I would never use CNI because there is no, unless the patient has,
Very
hypersensitivity to something else that you are using, or is you don't want to. So when would you not want to use alkylating agent based therapies? If you have someone in a reproductive age group who still wants to have children, both women and men, because the risk of azoospermia in men is very high, and women may develop ovarian failure. So you want to use alkylating agent based therapy as the last resort there. So rituximab you will prefer, and if because of some reason you cannot use rituximab, then only I would use CNI, not otherwise. If the risk is if the patient falls in the high risk category, then you can use any of these. CNIs you should not use alone there. You can use it in combination with if it has to be used at all. Again, I would suggest don't think of using it. You should use it in combination with rituximab, as was used in which trial? Starman trial, right? So, and if a patient falls in very high risk category, then the first regime of choice is cyclophosphamide and steroids. Or if you want to use rituximab, the recommendation, again, you can see the question mark there because we are not really saying that you should use it always, but if you want to use it, you have to use very high dose of rituximab, which the risk benefit profile of that approach is as yet unknown. And the other point, two other points that one I already mentioned that the risk stratification should be done at baseline and at 1 and 3 months. If you remember some of the old guidelines, they were very dogmatic in saying that we should wait for at least 6 months before deciding whether or not to use immunosuppressive therapy. Now, with the availability of antiphospholipase receptor antibody and better understanding of the natural course of this disease, that wait and see period has been suggested to be cut down to 1 to 3 months also. So, if someone continues to have very high anti-PLA2R antibody levels at 1 month and at 3 months, then we would go ahead and treat such individuals. And similarly, using antiphospholipase A2 receptor antibody level, you can also decide to stop treatment early if the antiphospholipase A2 receptor antibody levels come down and disappear very quickly. And that is where comes your comfort level, and you might want to actually go ahead and do an indirect immunofluorescence to really convince yourself that yes, the antibodies are truly disappeared.
Okay, then continuing therapy in such a patient, and especially if the proteinuria is also gone down significantly, then probably you may not need to continue immunosuppression in these So PLA2 antibody is a useful tool which a clinician should use in combination with clinical factors, and you can really use them effectively and help you in deciding as to what kind of therapies, when would you want it. One other question is, in the day-to-day management of membranous nephropathy, what kind of timetable would you suggest they should do? So one is that they do that at the time when they make a diagnosis. Subsequently, they've started the treatment. For example, they're given rituximab. And predominantly, I'm using this period for not going on as to what kind of therapies. We could talk about those therapies on some other day. But predominantly, how to use PLA2 effectively for your patients. And when would you want to do another test, and then how will it help you in monitoring these patients, and what kind of responses will you?
So you have a slide here which answers exactly this question that Professor Kher is asking. Is that you've started a treatment as shown in the box. It doesn't matter which treatment you have started, and now you have to follow these patients. And we are assuming that the patient had elevated antiphospholipase A2 receptor antibodies at baseline when you started treatment. Then the guideline says that measure antiphospholipase A2 receptor antibody level at 6 months. Now, you can see the box in the bottom that this 6 months is not a sacrosanct time period. Some centers will measure antibody levels at 3 months also, and we have done that in collaboration with colleagues at PGI. We have measured antibody levels every month, and we have found, and this is something which was also shown in the GEM-RETUX trial, that in most patients the antibody disappears in the first 3 months. In most patients who will enter remission, they will show disappearance of antibody in the first 3 months. So that is the most crucial period of time. I would suggest that if finances are not a problem, measure antibody levels every month. That would be my recommendation. But if finances are a problem, definitely measure it at 3 months. You have started treatment, measure the antibody levels at 3 months. And then, depending on what you find the antibody levels to be, you can classify this patient into this traffic light, red, amber, and green categories. If the antibody has disappeared, then at that time, stop the treatment. Right? You can stop the treatment. So typically, the Ponticelli regime is a 6-month regime. Right? But now the way we do it is that if we measure the antibody, we find that the antibody has disappeared. We repeat the antibody sometimes because there is a bit of fluctuation. Labs are labs, we all know this. We repeat the antibody levels after 2 to 3 weeks, and if there are 2 consecutive negative antibody level reports, then we'll stop the treatment. Even if we have used the alkylating agent based therapy only for 3 months, we would stop it at that particular point of time. But if the antibody has decreased, as you can see, but hasn't totally disappeared, so this is again a threshold less than 50, then you will continue with the rituximab based regime. Cyclophosphamide and prednisolone, you may choose to stop it at that time because the antibody levels were high, but they have come down to less than 50, and we hope that they are on a downward trajectory and they will disappear. Right? So if you decide to stop it because you think that cyclophosphamide based regime is a toxic regime, you don't want to give these patients any longer than absolutely necessary, that's fine. But you may also decide to continue it. I won't really find any fault with either of the 2 approaches. CNIs, again, don't use it, but for the sake of completion, CNIs should be continued. Right? But if the antibody levels continue to be very high, then reinfuse rituximab and cyclophosphamide prednisolone based therapies you have completed for 6 months because this is a 6-month based algorithm that was shown. Then of course you will stop it at that time, but don't leave the patient untreated, but add rituximab. Now, why this is important? A bit of explanation is required here. The studies that we did in the past, the paper, the trial that when I started the trial in PGI on cyclophosphamide prednisolone in membranous nephropathy in 1990s, at that time we gave the treatment for 6 months and there was nothing else for us to do. There was no rituximab. So we just followed up these patients and we saw that patients continued to enter remission for as long as 1.5 years. Even though the treatment was given only for 6 months, the effect of the treatment continued to come later on as well. And we didn't know this concept of immunological remission and clinical remission at that time. But now we understand that, right? Because it is likely that the patients had entered immunological remission and clinical remission just took a little longer to come in. Okay? But now that we know that you can predict whether or not a patient is entering immunological remission by following the titer, you know that if the titers are still high, then the patient hasn't entered immunological remission, and it is unlikely that the patient will enter clinical remission on his or her own. And therefore, there is a need to add a second line therapy right away, without the need for waiting anymore. All right. So this is the algorithm suggesting how you can best use serial measurement of antiphospholipase 2 receptor antibody levels in managing or optimizing a treatment of a patient with membranous nephropathy in such a way that maximizes the chances of success and minimizes the risk of development of unwanted adverse effects.
I think the reason I chose to discuss this with you guys today is that I get to see prescriptions of many, because I get second consults, third consults, fourth consults from nephrologists, and I find that despite KDIGO doing an excellent job in giving these kind of tables to help them from practice point of view, every time I find that there is such a written in the guidelines. So I thought it's very important for you to learn exactly from where the guidelines come from, and you should know that how you can optimally utilize this test effectively. Sometimes Dr. Jha tells you that you could do it, cost is not. The cost of the test is 5,000 rupees. In the long term outcome of these, sometimes we estimate costs in very, very different ways. And if you ask the patient that this is what is going to help me in identifying it, are you gone into a clinical remission? I am telling you, you tell this to the patient, you ask me, should I order this test? 100% of the time the patient would say yes. But many physicians in their own mind have made a decision that it's an expensive test, therefore I shouldn't do it. But then some information, stopping therapies, which I can tell you when we didn't have any of these, I didn't know which patient is likely to respond in 1 year's time, and as Vivek was saying, that many patients continue to be getting into remission over year and sometimes even year and a half. So clinical remission in membranous nephropathy is slow, and that's my mentor Victor Paul used to say that it takes about 1 year for patients to get into remission, and therefore he was looking at those were times 70s when randomized trials were not done. First randomized trial with high dose steroids came in 79 it got published. First randomized trial, and then it showed effect. Then 10 years later, a second randomized trial showed that was not effective. And he had argued at that point of time that you require more than 400 patients. And to do that kind of thing in a particular center is going to be extremely difficult unless you do a multicentric trials at that point of time. And multicentric trials in 70s were not very common. So it's only in the late 2000s that the multicentric trials and all other things started. So it's important to realize that remission is going to be slow in these patients. So utilizing these tests will help you navigate yourself into the crisscrosses and which patients you can stop. And this algorithm is very, very well done. That if the antibodies become negative, then you can as well stop, especially if it happens in first 3 months of time, you can stop and you can stop giving therapies. And high risk patients, change them to another group of therapies and all those. And the only place where I would feel I would use corticosteroids is an extremely edematous patient, and where the cyclophosphamide produces a relapse, remission earlier than rituximab. Rituximab might take some longer time, and the patient has not chosen to accept cyclophosphamide therapy. Is extremely edematous, hypoalbuminemia. Now, to expect that rituximab will produce a remission in such a patient is going to be extremely difficult. Not going to be happening in next 2-3 months and see severely edematous, then probably calcineurin inhibitors might help in those kind of patients to become less proteinuric and they might go into that kind of a remission. So you might be able to use diuretics more effectively in such a patient and produce symptomatically less edematous patient because proteinuria is going to take 3 to 4 months to reduce. That's the only place.
Just on the class point, we have actually shown this, and there is a letter to that we have published in which we looked at response to different types of immunosuppressive therapies that included CNIs also, in terms of their ability to lower the antiphospholipase A2 receptor antibody level. And we showed, along with Dr. Raja Ramchandran at PGI, that of all the, both cyclophosphamide-based therapy and rituximab caused a fall in the antiphospholipase A2 receptor antibody level, but CNI therapy did not lead to any fall in antiphospholipase A2 receptor antibody level. So it does not attack the immunological basic abnormality that is present. But as Dr. K was saying, tacrolimus or cyclosporin CNIs, they have some and non-specific antiproteinuric effect because of hemodynamic action on the glomerulus,
Yes.
right? So they may lead to some decline in proteinuria, but that should not cause you to think that the patient is showing response in by way of something improved,
No,
by way of
I think it was
improvement in the basic therapy, right? So if you have to use CNI, it should be thought of only as a temporizing measure, right? And that you want to buy some time.
Yes, for symptoms, basically
For
symptomatic
the therapy that attacks the root cause to become effective.
Right.
Because rituximab, even if one gives rituximab, there will be an immediate decline in the CD19 cells. But the antibody level is going to take some time to come back, right? And for that, you might buy time by using CNIs, but never think of using CNIs as the primary treatment or a treatment approach that attacks the basic cause of this condition in patients with.
No, I agree 100% with you that calcineurin inhibitors are being used predominantly to help the patients become less symptomatic because they are severely edematous and all, and diuretic response in many of these patients, severely hypoalbuminemic may not be possible on an outpatient basis, and therefore you might use this to buy time till the rituximab action occurs, and that's the only reason I would think this is.
The other implication of this is that if you have to use it, you should use it for 2-3 months.
Yeah,
There
definitely.
is no point in continuing CNIs beyond that time. You are simply poisoning the patient by exposing this patient to the toxic effects of CNIs and asking them to spend money on a treatment which is not good.
Yeah. It doesn't look at the etiology of the disease itself at all, and I would agree that I also keep it as the last resort only if both these therapies fail. But to tell you frankly, it's rare that when both these therapies fail, one of these therapies would be effective. And in some patients, you have to use both of them. That's true. I have used CNIs in, as I said, that in very severe symptomatic edematous patients for a short period of time, 2 to 3 months. And by the time they get into a remission, the CNIs are totally withdrawn. So that's one thing. Anything else you would want? Any questions from you? I want you to ask questions. Yes.
Sir, I just want to know that in case we talked about patient of the tissue plateau or staining, and then we talked about sink phenomena. So in patients who come as a high risk patient and is having this sink phenomena, so we don't have this immunological clearance for that to see, because at the start itself of the therapy, plateau will be negative. So will we be considering doing the biopsy again at 3 months or 6 months and see for the tissue clearing of the platua?
So, in membranous nephropathy, we are now getting away from doing even one biopsy. So, the question of repeat kidney biopsy to document remission is usually not something that will be considered in this situation. The important point to remember is that if you see a patient who only is tissue positive, but has negative antiphospholipase A2 receptor antibody in circulation, usually such a patient will show appearance of antiphospholipase A2 receptor antibody in serum at a later time point. And this also we have documented that some patients were negative at the time of diagnosis when the kidney biopsy was positive for antiphospholipase A2 staining, but 1 month later when their circulating antibody was repeated, it turned out to be positive because we caught them at a time when they were exhibiting the sink phenomenon, right? Because the sink will eventually get exhausted and antibody will start appearing in the circulation. Right?
So I would do the test if this is negative and you are very certain that this is membranous nephropathy. Maybe do a test after 1 month or so, a repeat test. And you could also use another method. If you have used an ELISA, then use an immunofluorescence method. So I think those would be the methods. And there are some centers which are suggesting where cost is not a consideration, use both the tests. But that's not
positive. You don't need to do immunofluorescence because you don't get any additional information at all. Right? So immunofluorescence should be used only if the ELISA is negative.
I would use that. Anyone else? Yes.
As we discussed, like regarding the anti-cancer receptor antibody monitoring, when the 2 consecutive tests comes negative, we should stop the treatment. We can stop the treatment. But at the same time, sir, like when antibody titer is negative, but to achieve the clinical remission, it takes 2 to 3 months. So I'm like confused when to stop the treatment.
So let me ask you a question. What is the goal of treatment?
To achieve the complete remission.
But how do you achieve complete remission? When you are giving this treatment, which is an immunosuppressive treatment, remember, right? Both rituximab and alkylating agent-based therapies, the goal or the way they work is by producing immunosuppression. And here, when we say immunosuppression, it's not some generic type of immunosuppression, but action on B cells to reduce development of antibodies, right? That is the goal. If once the immunological remission has been achieved, what else is an immunosuppressive therapy going to achieve?
That's the root cause treatment.
Right? You understand that, right? So you have to ask yourself the question, what else am I trying to achieve by giving further immunosuppressive therapy to this individual who has already entered a complete immunological remission, right? So you are not going to get any additional benefit by continuing the immunosuppressive therapy in such an individual, but you know, as someone who understands the pathophysiology of this disease, that clinical remission will take some time to come. So it is your job to convince the patient. If you yourself are not convinced, then it becomes very difficult for you to convince the patient, right? So you should be clear in your mind as to what is the goal of treatment. The goal of the treatment is to get the patient to enter immunological remission. Patients may not be able, not in this membranous nephropathy, of course, but in other disease conditions, patients may continue to have some degree of proteinuria because of other reasons, because some chronic damage has already taken place in the glomerulus. Usually it doesn't happen in membranous nephropathy unless there has been a delay in treatment, right? And in such a situation, patients may continue to have residual proteinuria, and that residual proteinuria will also not go away no matter how much immunosuppression you give to these individuals, because the mechanism of that proteinuria is not immunological mechanism. It is non-immunological mechanism, and therefore there is already some permanent structural change that has taken place in the glomerulus, and that permanent structural change will not be repaired by immunosuppressive therapy.
Now, one question which remains, I think, patient has gone into a clinical remission, is an immunological remission. How do you monitor these patients? That's more than that.
Yeah. So you of course, the patient has gone into clinical remission, immunological remission. So you can take two approaches. I think eventually, what you are concerned about is the patient doesn't develop clinical relapse. So you can monitor the proteinuria. That is one way of doing it. But if you want to be even more diligent in the way you treat these patients, it is quite appropriate to monitor their antiphospholipase A2 receptor antibody levels also. And you can decide at what rate. There is no evidence-based guideline right now because no one has done that study to see what is the optimal frequency of monitoring. But I think it makes sense to monitor the antibody levels every 6 months if you want to do it. That's what I do. I ask my patients to get an antibody level repeated at 6 months interval after they have tested clinical remission.
And usually an antibody titer might go up before a clinical relapse.
It will always go up. It should all, and that has been shown now in serial follow-up studies that antibody rise in antibody titer is followed by development of clinical relapse. It is not preceded by clinical relapse. Always the antibody goes up first, followed by increase in proteinuria.
Any other question? Any other question? Anyone else? Yes. Don't hesitate yourself. If you have something going in your brain, do ask.
Sir, in cases again, in this chart itself, when we say the plateau has decreased to less than 50, so we continue with Retux, but when it comes to cyclophosphamide, it said stop and go.
Cyclophosphamide 6 months is a 6-month time. Usually
Regime
cyclophosphamide will
is
not.
finished at that time, right?
That regime is for 6 months. Rituximab therapy continues for 6 months, 12 months, and then even
The
at
general
18
principle
months.
now with rituximab therapy for many disease conditions now is that you may need to keep on repeating it for many years here. For example, in ANCA vasculitis, right? You may need to continue to give rituximab for
every 6
very long.
months or so. Every 6 months for long period as a maintenance therapy. That has been shown that Ritux is
Once
better
again,
than.
you have to understand why this is done. Why this is done? Tell me why this is done. Why would you want to continue to give it every 6 months? It's very simple. It's not a trick question.
Because the B cell depleting effect of the rituximab will
You want to
Continue
you want,
to have a B cell.
the antibody production to continue to stay suppressed, and that the only way that can happen is if you continue to suppress the B cells, and the effect of rituximab does last for several months.
So usually 6 months, and that's
If you want to be
rationale for that.
even more accurate in the way you time this, you can measure the anti-CD19.
So anyone else? Any other question? Yes.
So like you mentioned that some centers would be measuring at 3 months, and then they would, if there is remission, then sir, in that case, therapies like involving cyclophosphamide, which would be for 6 months. So if the remission is at 3 months, for the remaining 3 months, do we continue the?
No, we would stop it.
You would stop.
My practice is to stop it at that time.
So even the modified Pondicherry cell.
Yes.
You can stop therapy because this was not available before. Now that you have this test available with you,
This
you
is the
could
point
stop.
of using this test
Using this
because you
test.
can tailor the therapy more accurately
Accurate.
to the patient. Not everyone will show disappearance at 3 months, 1 month or 3 months. But if someone shows disappearance, give them the benefit. Why do you want to continue to poison them? I use the word poison deliberately because that is what we actually do. We poison our patients. Sometimes poisoning, this is an old saying, poisoning is beneficial, but you don't want to do it unnecessarily.
So when you mentioned that if the immunological remission is seen by the ELISA method and we want to be sure we can use the immunofluorescence, so is there any specific cutoffs that we should be sure that okay, if ELISA is negative and on immunofluorescence, if this much is the titer, then we can say yeah, it's for sure.
In immunofluorescence, negative is negative.
Yeah.
Negative.
And if it is positive, okay, then that means
Then
That means that there is still immunological activity.
Yes, that's.
Sir, after giving modified Pondicherry, for example, we are giving to a patient and we are given for 6 months or rituximab. So after till how long we should wait before we can see or can say that the patient is not responding, or should we give some time? Is there a time frame till which we wait after administering the therapy to see for the response?
Yeah, so this is this algorithm tries to show, right? That you monitor the antibody level at 6 months. If the antibody level is still in the high range, let's say more than 50 or more than 100, right? Then it is unlikely that the antibody will come down further
With the same
without any fresh intervention. Alright? Then it is unlikely. It is not that it will never happen. You know, please don't get me wrong. Sometimes you will see patients. This is the point of medicine, right? Medicine is a game where you play the odds. Medicine is not a game of certainty. For example, even if you are treating community-acquired pneumonia with a particular antibiotic, you cannot guarantee that every single individual treated with that antibiotic for X number of days will show similar type of response. Right? You play the game of odds, and whenever you decide whether or not to use a treatment, you have to make a judgment that the benefit from using the treatment is going to far outweigh the potential risks of that particular treatment. So it's like playing the odds. Those who have played cards, they know, when to fold and when to do. If you have played bridge and other similar card games, you will know that, right? So you make that mental calculation, and you have to do that for every case. Every case is somewhat different. The guidelines will provide you with a broad direction in which you should think, but you will need to make the judgment in an individual case, and that judgment is of course informed by medical criteria, but there are a number of non-medical factors also that come into making that decision. I gave you one example. If you have someone in a reproductive age group, you will think somewhat differently, right? Similarly, you have to look at the infection risk of a given individual. Right? You have to see where does the patient come from. If the patient comes from a far off place where access to certain type of monitoring mechanisms may not be available, then you will be forced to think somewhat differently. And similarly, there are other factors also that you will have to keep into mind.
Anything else?
Sir, I have a question.
Yeah.
Sir, if after 6 months, sir, in the last diagram, sir, if the titer is still high and if initially we had used rituximab, why don't we switch to cyclo?
You can.
You can switch. You can use rituximab. It's like any other therapies. You have lupus. If there is, you use mycophenolate mofetil, then you use cyclophosphamide. If you use cyclophosphamide as the first drug, then you change over to, if they don't respond in 6 months or 1 year, whatever the cutoff for estimating remission is or response is, then you change to another therapy or add another therapy.
So the advice to reinfuse is with the presumption that this is likely to be a less toxic.
Yes.
This is likely to be. That is the presumption that we are making here when we say that you just reinfuse 2 more grams of rituximab. And when we say 2 grams of rituximab, you give 1 gram, and then 2 weeks later you give 1 gram. That is the approach that we take.
Anything else? Yeah. Okay. Yeah. Please don't go to sleep with questions
should
in
we
your
treat
mind.
immunological relapse before clinical relapse occurs?
Sorry?
Should we treat immunological relapse before clinical relapse occurs?
Very
If
good
antibody,
question.
antibody is present, but there is no proteinuria.
Yeah, very good question. Again, there is no data, so there is no evidence-informed answer to your question. As for myself, I will not treat this immunological relapse. I will wait to see what happens to the patient. Maybe there is an immunological relapse which will become quiet on its own. I don't know the answer to that question. But if a patient develops clinical relapse, then of course you have a stronger justification to treat the patient.
And this is with other antibodies also. Anti-antibodies by itself do not make somebody to give therapies without a clinical kind of lupus also. Anti-dsDNA antibodies may not come down in some patients and may continue to do that. So unless they have a clinical kind of a relapse,
You're treating the clinical disease. Bad things will happen to the patient only if there is overt clinical abnormality.
So treating asymptomatically at that point of time, we don't know the answer, but it's quite possible that in future we might have a definitive answer which could be contrary to what we are telling you right now. It could be. So don't get surprised that we told you something this time and 3 years later or 5 years later you can come. I have had students come and tell me that 20 years back you taught us this thing about this and now you are making different statements. I said you haven't read. I continue to read. Therefore, I will make different statements because things keep on changing, and that's very important for you to keep on with the literature and now what things are happening. I think we'll, yeah, one more.
Opposed to plateau negative primary.
Right. So when we plot to negative primary membranous nephropathy, in there is stratification, you just don't use the plot because you don't have that, right? So there will be patients with non-PLAR related membranous nephropathy, right? There you don't have any antibody level to monitor. There you go back to the pre-PLAR2 era and you use all the other parameters that you have to do risk stratification. Risk stratification is still possible. PLAR2, again, I have been making this point repeatedly, PLAR2 is not the only factor that helps you risk stratify these individuals. So please do risk stratification and treat these patients according to their risk category.
Yeah, that's important actually. Yeah, I missed that. That those patients who are plateau negative at the moment, we don't have serological measurements of other antibodies. So we can, although we may be able to do them on the histopathology, but at the moment, plasma or serum levels are not available at the moment for monitoring purposes. I think NEL has become available in some countries now, and NEL1 is antibody monitoring is possible probably in some countries, but in our country at the moment we don't. Thank you very much.